So I am here with my good friend and colleague, Nancy Momoff, at the 19th World Congress of the International Menopause Society. And Nancy and I thought that we would get together and just tell you some key takeaways that we have taken away from the conference. So over to you, Nancy. Tell me what you thought.
Well, firstly, it was just so great to be in a room with all these amazing women from all over the country and all over the world that are so passionate about women's health and menopause. So I think we really are making a lot of inroads into this topic. So it's a great time to be part of the menopause movement. So that was really exciting. I think my top 3 takeaways were that cardiovascular risk is decreased by 50% if HRT is given within the golden window of 10 years after the last period or under the age of 60. So that was really reassuring and quite exciting.
And that's so good because we have to always remember that cardiovascular disease remains a leading cause of death. In both men and women. So anything that we can do to reduce that is going to be amazing. So that was kind of really good news. What we suspected, but good news.
But unfortunately, there was a caveat that we still can't use it as primary prevention. So that was still a bit disheartening, but who knows? Hopefully in the future that might change. So that was the first one. The second one was the testosterone evidence. So we were talking about it in the context of HSDD or hypoactive sexual dysfunction disorder.
Otherwise known as
low libido. Exactly, which is probably one of the number one things that women come to see me about. So as long as it remains within the physiological range for women, transdermal testosterone is very safe to use. And there is some exciting pilot data coming out about the use of testosterone for cognition, for muscle strength, and for bone density. So hopefully we will see all of that in the future. And the third one, there was a great head-to-head debate with Prof. Kulkarni and Pauline Mackey, and they were talking about what to use as first line for perimenopausal depression. And I think I'm probably on the Prof. Kulkarni side about using MHT or HRT as first line, which in my practice I think is very useful as well. There's always the SSRIs and antidepressants to fall back on, but I think in this particular cohort of women, I think it works really well.
So for anyone listening who's not medical, what do we mean by first line?
First line would be the first thing that I would try in somebody and then maybe go on to the SSRIs. I don't think it might not be that for everybody, and it's definitely an individual case-by-case decision, and there should be definitely patient collaboration with the doctor. But I find in my practice that women actually respond really well to hormone replacement therapy in the majority of times. So really good.
I agree. And so that was your 3 main takeaways, which is awesome. Do you have a favorite quote of the conference so far?
I do. So John Stevenson was giving us a really great overview of cardiology, and he is from King's College in the UK. And he said that people always try to find ways to say that HRT is not good, but I'm afraid it is. And I just thought that was perfect and just totally summed up what we all know, that, working in the menopausal space, how good HRT is.
Yeah, absolutely true. I absolutely love that. Say that to me one more time.
People always try to find ways to say HRT is not good, but I'm afraid that it is.
Yay! I love that because we know that it is so good and we love using it in the vast majority of our patients. And it's absolutely not for everyone and not everyone wants to take it. Exactly. But I think everyone should be allowed to have the conversation with a knowledgeable health professional to help them make that decision.
100%.
One thing that I hear repeatedly from all my new patients is that often their past experiences with appointments to address their symptoms of menopause have made them feel rushed, unheard and frustrated. As a doctor of 25 years with first-hand experience and understanding the many symptoms that one woman may encounter in her menopause transition, I knew I couldn't do this subject justice in a 15-minute appointment, which is why I've created the Menopause Appointments, designed to support you on your journey through the perimenopause and postmenopause. This 60-minute session gives you and your doctor the ideal amount of time to understand your concerns, needs and desires. It gives us time to do a comprehensive assessment, including a full review of your medical history, assessing your mood, your sleep, weight and libido, and much more. Receive referrals for tests as needed, prescribe suitable medications if required, perform a skin analysis and leave you with a comprehensive tailored plan unique to you. This is crafted to help smooth your transition through the perimenopause, postmenopause, and allow you to thrive, not just survive. If you or someone you know is experiencing perimenopause or continuing to have symptoms in the postmenopause, these appointments are for you. You can book an appointment with one of our doctors today. We have clinics located at Forster Speech and Newcastle, and you can book online at youbydrshaunawatts.com.au. So today I'm with my good friend, Dr. Ceri Cashell, who has been a real favourite on the podcast before. Ceri, I would love you to tell me what your 3 main takeaways from the conference have been this year.
Yeah, so it's been a really exciting couple of days. I'm sorry to be leaving now, but we've had some amazing talks. And I guess for me, a lot of the information really consolidated and reassured things that most of us who are working in the kind of menopause space know to be true. But it's nice to hear the experts say, yes, those things are true. And the first one would really be about bone density. It's not necessarily the sexiest topic, but it's one that I've become really passionate about. I now try to screen all of my menopausal women very early with a bone density scan. Unfortunately, in Australia, we don't screen women routinely until they're about 70, unless they've got a very high risk factor. And at 70, really, the horse is bolted, fallen at the first gate and broken its hip, or in this case, a woman. So it was really exciting to listen to Prof. Bronwyn Stuckey talk on the use of MHT, particularly estrogen, in both the prevention and treatment of bone density loss. So that was probably there's a couple of talks that were amazing. That was probably one of my top 3 talks. And she really, this is her subject of, to her heart, to her, her favourite subject. So she talks about the other drugs that we really routinely use. And there's quite a few other drugs that we can use for treating osteoporosis. And she called them drugs of, weapons grade medications. And I think, again, it really highlights how scared we have been of the wrong medication, how scared we are of estrogen, and we don't necessarily apply that level of caution to other drugs that we use. So really, she said, estrogen is the bomb for bones. It builds up bone, it stops it being resorbed, and it also doesn't carry the small risks that other drugs carry. Like you can get these, what we call atypical fractures with long-term use of the other drugs that we use for treating osteoporosis, and estrogen does not have that. So really looking at using estrogen early in the piece to maintain a woman's bone density. Osteoporotic hip fractures carry a huge risk associated with them. Not only do they affect somebody's mobility, but a woman who has an osteoporotic hip fracture, so a hip fracture secondary to that bone density loss, they have a 20% risk of dying in the year after their hip fracture. So not one of our sexier topics, but a huge cause of loss of independence, mobility, and, good health, and, really affecting health span of women. So I was sort of sitting there just getting really excited and jumping up and down my seat and going, go Bronwyn. So that was awesome.
Okay, well, I'm going to just stop you there and ask you 2 quick questions about that. The first one, you're saying MHT,
yep.
And some of our listeners mightn't know what that is. So can you just confirm what you're talking about?
So largely, when we talk about MHT in the case of bone density and prevention and treatment of bone density loss, it's a lot of the data would be around estrogen. So we've got data for different types of estrogen. So from the old study that ran over between 1998 and 2002, which was the WHI study, they used conjugated equine estrogen, which is the horse's urine estrogen, and it shows a reduced risk of fracture. But we also have really good data for the body identical estrogen, estradiol, which we can deliver both as a tablet but also as a patch or a gel. And where that comes into its own is that because it's going through the skin, it is much safer in older women or women who have other risks or contraindications to using an oral estrogen. So, older women. So we've seen from other studies that you can use a transdermal estrogen through the skin in women up to the age of 80 safely, and it improves their bone density, which is pretty cool. but it doesn't have this risk of clot. It doesn't have a risk of stroke or heart attack that we know of. There's some concern at higher doses it might do, but certainly at a low dose it is effective at treating low bone density without risk. So estrogen is the drug really that she focused on, and it is the part of MHT or HRT that has the most bone data. There's a little bit of data in osteoporosis with both progesterone, natural progesterone, and also testosterone, but she wasn't particularly talking to that. She really focused on the estrogen part of MHT or HRT.
And Ceri, as you say, osteoporosis isn't really considered a sexy subject to talk about. And so what would you say to any peri or postmenopausal woman who is hearing this and thinking, oh, well, hip and wrist fractures, that's something that happens in their mum's age, in their 70s or 80s. Why is it important that we think about this at this stage or even earlier?
So we now know that actually women lose their bone at the fastest rate in the 3 years before their last period and probably the first couple of years after their last period. So it's the time of fastest bone loss, and that's particularly relevant to women who are slim or women who are starting with a low bone density. So women who've had prolonged periods of time where they've not had a period, secondary maybe to overtraining if they're an athlete, maybe if they've had an eating disorder, or women that have been on steroids or certain other conditions. So they can enter the perimenopausal phase with a low bone density, and those women can lose bone really quite quickly in those 5 years around the time of menopause. You still continue to lose bone after that point, but it's at a slower rate. So often when we're doing these bone densities, we've really missed a huge amount of time where your bone has been getting lower and lower and lower. And even if you don't fall and break something, you can have these fractures in your spine, which don't necessarily need to result from injury. They can just happen spontaneously. And that's, you see women starting to shrink as they get older. Certainly as somebody that's 5'1"3/4, I am very protective of those 3/4 of an inch. And if I had some undiagnosed vertebral fractures, I might even go below 5 foot, which would be just horrendous for me. But so women in this age, they really need to think about their bone density. It's not sexy. It's not as sexy as heart disease, but you can have a bone density in Australia. It's very cheap. A lot of places, even if you don't meet the criteria to get it on our rebate system, it's only about $100. And I think really around about the age of 50, certainly, and certainly for women who are in high risk groups, and you should talk to your doctor about that. Women with celiac, rheumatoid arthritis, previous eating disorder, they should routinely have a bone density. So really important to pick it up early so that you can come in with hormones if that's what you want to do, but also weight training and making sure you're eating enough protein, because those are the other two modalities that will improve bone density.
Okay, amazing. I love it. Next.
Okay, so my second takeaway is another one that I feel was reassuring to me, where I sometimes feel I'm a bit of a maverick prescriber. So I don't like to use very strict rules. So if somebody comes in on age 61 and they're over the age of 60, which has traditionally been considered the upper age limit for starting somebody on menopause hormone therapy, HRT, whatever you want to call it, I've always liked to sort of look at the patient in front of me, talk to them about what their symptoms are, where their bone density is, and is it right for them. So really a big takeaway from multiple talks, even people I would have thought were quite conservative, was that there should not be an upper age limit for starting MHT, HRT. Certainly in women who are over 60, more than 10 years after the last menstrual period, we should be probably using a transdermal estrogen because it has a much higher safety profile where you might have risk factors. But that I was particularly excited by the talk at lunchtime today, which is a debate about this very topic. And Professor Susan Davis said that she had started transdermal estrogen, so an estrogen patch, very low dose patch, in a 93-year-old woman who was having persistent hot flushes in her 90s that were very distressing. And I think, we as GPs, we see all these women who've been denied, really actively denied MHT or HRT, or who haven't known about its benefits, who really feel they've missed out. And I don't think it's right that they are excluded from this conversation. And while I'm not saying that everybody over the age of 60 should start HRT, MHT, I think there are women who can absolutely benefit both for quality of life, but also, looking at their bone density.
Okay, amazing. I love it.
It's very exciting.
Have you got another one for me?
I do. This one's probably, again, would be a very specific population of people, but I see a lot of women, who in my practice who are going into perimenopause a bit earlier, and then there's the women who have gone into menopause as young as their teens. And even in my normal general practice population, I have, this young group of women who have stopped having periods, at a very early age, and how important it is for them to have their ovarian hormones replaced in the form of, really it is hormone replacement therapy, and considering all three hormones, estrogen, progesterone and testosterone, because we know that those women have a really significantly increased risk of multiple chronic diseases, from cardiovascular disease to dementia to kidney disease to osteoporosis and quite a few other diseases. So it's really important when we're looking at that population of women that we do give them their hormones back. There's a subgroup of those women who have had their ovaries removed to reduce the risk of ovarian cancer. So those would be our women who have the BRCA1 or BRCA2 gene. And there is still a lot of concern, both from specialists and certainly from GPs, that if you carry the BRCA gene mutation, it's not safe for you to have hormone replacement therapy. And there was a fabulous doctor from Israel, Dr. Howard Karp, who presented an excellent lecture that really showed that these women can safely have hormone replacement therapy when they've had their ovaries removed to reduce the risk of ovarian cancer. Whether or not they've also had their breast removed to reduce the risk of breast cancer. And I think that is a really important message. I presented a poster for News and Health which looked at how many women are given HRT across 3 trusts in the UK, and 95% of women had not been offered HRT after their ovaries were removed. And I think that is really negligent, So it's not something, I know what the data is here in Australia, but I've certainly met a lot of women who have not been offered hormones when their ovaries have been removed. And it's been a case of, well, let's just see how you go. And we don't remove other, organs that still have a function and say, well, let's just see how much you suffer. So really important, especially for our women who carry the BRCA gene.
Yeah, absolutely. Okay, that one's a close to home one for me. And quote of the conference.
Oh, well, I have multiple quotes, but I think my favourite one from today was, and I've inserted the word real, so that is my own little sort of tweak on it, but real doctors don't always need to know how a drug works. They just need to know if it works. And research is so important. And yes, we need gold standard randomised controlled trials. But in reality, a lot of those trials are not going to happen in women because we get such a little part of the research budget. And a lot of those trials need to be of such a duration if we look at things like dementia. But as doctors who see real patients, like if we listen to our patients, we can tell if things work. And there's a lot of sort of talk about a lot of it's placebo, but I see women, their symptoms get better that they didn't even think were associated with perimenopause and menopause, and like the itchy ears or the tinnitus, and all these weird and wonderful symptoms can respond to hormone therapy. And I think, although there's no randomised controlled trials, for instance, in the resolution of an itchy back on HRT, if you listen to your patients, you'll start to see patterns emerging. And I think if you do that, you'll just see a whole new type of medicine.
Absolutely, I agree 100%. We need to, it's all very well to have guidelines and tick boxes, but the reality is that we all know the humans don't fit into guidelines and tick boxes, and we need to treat the person in front of us.
Absolutely. And as GPs, I was told that we're not specialists, but a good GP is really the ultimate specialist in whole person care. So I would disagree that GPs aren't specialists. I think we are pretty much the badass specialists of menopause.
Woohoo! Yay! All right. Thank you so much.
Thank you.
This podcast and any information, advice, opinions or statements within it do not constitute medical, healthcare or other professional advice. Information is provided for educational and entertainment purposes only. If you have any health concerns, always consult your doctor.